All right, well, welcome everyone. So let me just pull up the slides. I feel like the new academic year is starting off with people getting here earlier. Just give me 1 second to pull up my slides. Okay, great. So my Zoom updated and it appears to have a little bit of a lag, but hopefully, and there's like different buttons, but hopefully this is coming through okay. All right, so for today, as we start off in the 2024 academic year, we're going to start off with a review from AIDS of 2024. But before I talk about that, I did just want to mention that next week is the CFAR scientific retreat, annual meeting rather, and there is going to be the B. Frank Polk lecture from 12 to 1, and in this time slot next week, in person at the Bloomberg School of Public Health. And they're going to be hosting Dr. Philip Goulder, who comes from the University of Oxford. And he has been working on, with his group, sex differences in perinatal transmission. And for those of you who know what my research life is, you know that I have a lot of interest in sex differences. But I think that the work that he's been presenting that's been coming out of his group over the last few years is really fascinating. So would definitely highly encourage people to attend that. And there is a registration link. It's on, if you search your email, there was an email announcement for the scientific meeting and the lecture on Tuesday of this week. Okay, great. And so upcoming conferences. So next week is the CFAR retreat and the Polk lecture, and then the following week is actually an ID town hall. But on September 27th, we'll be back with a case discussion. And then in October 11th, I'm just highlighting this, it's a little bit down the road. Will be a presentation from Dr. Greg Kirk on HIV and aging. And we're also looking to schedule an update on anal dysplasia screening in the near future. So, and hopefully also Sue Eshelman will be coming to talk with us about Levi syndrome, but all in the planning for the rest of the year.
Hey, Eileen. There's also an MPOC symposium on September 26th. So I'll drop that in the chat as well.
Right. So that's a Thursday, right?
Yes. Oh, I'm so sorry. I thought you were just in general.
No. This is yes, no, absolutely. I wasn't excluding it because of the day of the week, but just so that people have in mind that you don't have to miss this conference, you can go to that one too. And is that in the morning? Am I recalling that correctly?
Oh, sorry. It's 8:45 to 2 p.m. And I just put the link in the chat.
Great.
And serving lunch.
So keep that in mind. There's free food. And thank you for reminding me. That's great. There's so much going on in September with all these conferences and updates, but it's a really great time to do lots of passive learning, which I love. Okay, great. And Joyce, anything else that we should be aware of? Any operational stuff or things from the clinic? I know that there was at least an MPOX suspect recently. We've had some more COVID cases and suspects in the clinic over the last few weeks, just from the times I've been there. But anything else you wanted to highlight?
So, the workflows have not changed. So we have a COVID workflow and sort of screening algorithm. We are able to send swabs for for COVID in the clinic, but we'd prefer to have people evaluated by video visit and, rather than bring people in if possible. And then in terms of Mpox, there still are cases from clade 2, which is the clade that caused the 2022 outbreak that was mostly among men who have sex with men. So that is something to continue to have on the radar. And these are individuals who both may or may not have previously had Mpox, may or may not have had vaccination. It does look like vaccination does decrease the severity of illness, and then also does prevent. So we do have Mpox vaccine available, and I'll give a little bit more about that piece in just a second. That's, and then we have had people diagnosed at Hopkins who have tested positive, including people who've been hospitalized. So, and the people most at risk for severe illness are those living with HIV who are not on treatment and are immunocompromised. So, just to make sure to keep that on the radar, to continue to offer vaccination for anybody who is at risk for an STI. I would recommend that they get vaccinated. I think everybody has heard about the clade 1 outbreak in Africa. It is a health emergency declared by the World Health Organization, and there have been cases now identified in Europe and in Thailand, and we suspect it's only a matter of time before it comes to the US. This outbreak is more heterosexual contact, and then household contacts, women and children being impacted. This is clade 1. It also looks like it is more fatalities related to infection as well. And so that is part of what we're going to be talking about more in depth at that symposium. Again, in terms of testing, there is an algorithm for that, a protocol for that in the Bartlett Clinic. And Stephanie Thomas is our nurse champion, and really helps arrange for that to be done in an organized and appropriate fashion. And people can always reach out to her, and also please do include me as well in terms of if you have somebody who's a suspect and then you want to get them tested, and then also just in terms of treatment options. The STOMP trial is still happening, which would be the preferred route if somebody does have Mpox and needs to be treated. But if that is not feasible for whatever reason, we do have Tecovirimat available otherwise. And then on the inpatient side, we have been able to successfully get treatment, more comprehensive treatment for people who are more ill and have been hospitalized. So, obviously this is a increasingly of concern in the US, already very much of concern internationally.
Well, thank you for all of those updates, and that's a really good advertisement for this monkeypox symposium, because we should all update our knowledge. And thanks for also for having all those protocols in place to make clinic go smoothly. So great. All right, so let's get started with AIDS 2024. For just very briefly, before we dive into a little bit of some of the interesting science that came out, I did want to invite Leon, who is on the call and is our amazing, who is an amazing nurse to work with. I've had the opportunity to work with him when my own fantastic nurse has been out for various reasons, and who works with our ACE program. And Leon had the opportunity to attend the meeting, and he and I have been talking in clinic about how to bring different perspectives to these kinds of meetings. And AIDS is the kind of meeting that has multiple different tracks. So there's a scientific track, there's a clinical science track, but there's also implementation science tracks and community, heavy community engagement and representation in driving the progress forward. And it is a much more diverse conference than many other scientific conferences that I've attended. So I had asked Leon to just give us like a few thoughts on his participation and what he took away from it. And so I'll give the floor to him.
Thank you, Dr. Scully. So it was a wonderful event to attend. This is actually my second time attending, but like 22 years in the interim. And I jumped from all the different tracks. So it was a bit of a hodgepodge. So what I've been left with is a emerging lay of the land, both from the medical perspective, but then from the civil society perspective as well. It seemed like there was a lot of energy around where to go to next. There's some angst on the civil society side around funding and continued engagement. A lot of the money that does remain and that has been pledged and has been realized has gone to medical interventions. But there's been a lot of conversation around how to also support that when some of these places they need civil society actively engaged, so special populations, so sex workers, men who have sex with men, places like Kenya or Uganda, where a lot of the people who are living with HIV are also then criminalized in these other ways, making it difficult to reach them. So there's a lot of conversation around how to do that. And finally, how do nurses help with this? So the nursing model in other countries varies, right? So I was talking to one of my colleagues in Botswana, and their work is, while they do all of the running of the work, it's a heavily regimented thing. So they have their protocols, they interact with their patients, and they deal with a large volume of patients. Versus some of our work here. So what are the opportunities, right? So what are the opportunities to help think through how we deliver HIV care, how to also address some of the community-based questions when it comes to how to support our patients, not only in making sure they, get access to medication, get tested, but then also kind of how do they also then able to participate as a full individual in their societies. So it was very interesting, lots of thoughts to come.
Well, thank you so much, Leon. And I think one thing that Leon and I have sort of started a conversation about is this idea of using conferences as this engagement point to like think again about what we're doing in our own community and have that be a multi-level and multidisciplinary conversation. So we're going to commit publicly to trying to organize a conference where we'll have representatives from pharmacy and our MAs and our nurses to try to think about how we're addressing our community needs and applying some of the research that we learn about. So thank you so much, Leon, for that. And we have committed, so now we have to do it.
Indeed, thank you.
Okay, great. So I will just start off with, for those of you who were here in late July, this is a review. I just cannot not talk about it again very briefly. So the simultaneously published in the New England Journal and presented by Linda Gale Becker at the meeting was the Purpose 1 trial. The rationale for the study, greater than 3,000 new HIV cases per week in Southern Africa as of 2022. And while oral PrEP has been effective, there are multiple barriers, both at the patient level and at the implementation level. So this is a phase 3 randomized double-blind active control trial with 25 trial locations in South Africa and 3 in Uganda, in cisgender women where their incidence of HIV is greater than or equal to 3%. So the trial design actually used this incidence at screening and then a detuned type of ELISA where they looked at antibody avidity to determine recent infection and use that to calculate an incident rate for those who presented for screening for the study. So instead of having a placebo arm, they screened a lot of people and they identified people who had HIV at screening who did not previously know about it, and they used an assay to determine recency of infection to calculate a rate of recent infection. And then they used that as their background incidence rate and compared it to 2 active control arms. So really innovative and a way to move forward studies for prevention techniques where it becomes not ethical to do nothing. You can't offer people nothing when we know that there are things that are effective. So the oral PrEP regimens were FTAF, which, as everyone knows, has not actually been formally studied in cisgender women whose risk is vaginal acquisition until this study. Oral FTDF, which is the approved mode of pre-exposure prophylaxis for cisgender women who have a sexual risk of acquisition. And then subcutaneous lenacapavir every 26 weeks, so twice a year. And so what were the results? So just to jump to it, there were 0 infections and 1,939 person years. And it's just so amazing. And like, just hard to not feel like this is just a watershed moment. In the lenacapavir arm, 55 incident infections total, 0 in the lenacapavir arm, and the background incidence was 2.41. So what else did they learn? So adherence to injections was 91% at the first injection, 92% at the 1-year time point. In oral PrEP, 92% of cases had low adherence. And in a pre-selected group of 10% of participants that were assessed for tenofovir levels, most participants in both groups had low adherence, which was defined as less than 2 tablets per week. So the results actually showed that oral PrEP was not efficacious in either arm. So there was no difference between tenofovir disproxil and tenofovir alafenamide, but neither one of them were actually effective at pre-exposure prophylaxis. And this was, as has been shown in other studies, again, due to low adherence to the oral medication, and in really marked contrast to the amazing efficacy of lenacapavir. So where to go from here? So superior to background incidence and also to FTDF, there was no difference between FTAF and FTDF. And this novel study design creates a way forward. I think, to Leon's point, there was a lot of active discussion about when this would be available to the people who need it most and how we're going to fund access to this type of treatment, which could really just be absolutely transformative if we're able to achieve 2 injections a year and prevent acquisition of HIV. Another note I didn't include on these slides, but there were 510 pregnancies on study, which is also an amazing amount of data to now look at pregnancy outcomes and to try to get ahead of that curve. The average time between approval of an antiretroviral agent and data in pregnancy has varied to up to as long as 10 years in the past, but typically lags. And for, in particular, young women at risk of acquiring HIV in sub-Saharan Africa, being able to counsel about reproductive potential, especially when requiring a forward-thinking 6-month time period, is really essential. So hopefully we'll get some more data from that as well. So the next thing I wanted to cover, and I'll just move past that because we did talk about it once before, but it's just so important, just couldn't resist mentioning it again, is a little bit more on prevention. And so this one, I'm going to walk through a bit slowly and then maybe see if I can get some reactions from people here. So this was presented by one of my heroes, Rafi Landovitz. And the title of the presentation is The Performance and Characteristics of HIV RNA Screening with CAB Long-Acting PrEP in HPTN 083. So this study was built off of the HPTN 083, which was a phase 3 trial in the prevention network in cisgender men and transgender women who have sex with men. And that's currently in an open label extension, or OLE, period, because the initial study comparing CAB long-acting every 2-month injection, so it's a 1-month load, so dose, 1 month later dose, and then go to a 2-month interval, versus daily TDF FTC for PrEP, showed that it was efficacious, and therefore the study was stopped, but actually it was superior, and CAB use was approved. Multiple people in the study rolled over to continue on CAB LA. A small proportion continued on their oral PrEP due to patient preference, and they have continued to do other analyses following this population. So here they're looking at the performance of HIV RNA for testing for PrEP. So what is the background here? So in the HPTN 083 study was also the first description of the Levi syndrome. This is long-acting early viral inhibition. So when a long-acting agent can suppress viral replication early after infection, and this actually limits the ability to determine that a person has acquired infection. It's not associated with acute retroviral syndrome in the same way. And again, hopefully Dr. Eshelman will be coming to talk to us a little bit about this. This long-acting inhibition delays the detection of HIV, in particular when antigen and antibody or antibody screening strategies alone are what's used to monitor for HIV acquisition. And so there was data that we've talked about in this meeting before, where they went retrospectively at trial participants and tested samples from prior to a seroconversion confirmation. So these were participants in the CAB-LA PrEP studies who ultimately acquired HIV and were diagnosed based on antigen-antibody combination testing and confirmation. They looked at those participants, but went back to visits prior to the recognition of infection and tested for HIV RNA. And using that strategy, they were able to identify the majority of participants who developed infection prior to their antibody conversion. And in some cases, they were able, well, most actually, able to find those individuals before they developed resistance to integrase inhibitors. So they could identify that they had acquired HIV infection, and this would have allowed the initiation of a full regimen for antiretroviral therapy, which hopefully would have prevented the development of integrase resistance, which did occur in a few of the cases of breakthrough infection. So the current study was a prospective evaluation of using HIV RNA testing at each injection for earlier detection of HIV during the open label extension or OLE phase. This is currently the recommendation and the practice in most higher income settings. So just with that as background. So that was the purpose of this or the design of this study. So the testing procedure, so they did site-based rapid antibody testing that was resulted prior to injection. So you had some sort of screen that would tell you HIV antibody positive, like a rapid test on the spot. They also had blood drawn for antigen antibody testing and for HIV RNA testing. And these two results were not necessarily resulted prior to injection of your CAB. Your HIV status was determined by an independent committee that reviewed results from the site, as well as retrospective testing at a central laboratory. And review triggered by any positive or reactive HIV test results at the site. So that's how they selected all the cases to look at. And so they calculated the statistical performance of a single HIV RNA at a visit, and they had 2,619 participants with 26,000 visits and 3,800 person years of follow-up. So a very robust sized data set, as is needed for pre-exposure prophylaxis type of studies. So here's the key for all the pictures. So the blue people are adjudicated to not have HIV. The red people are adjudicated to in fact have HIV. And the black people we don't know whether they actually have HIV or not based on the current status of their testing. Then there's a couple of different test things. So the test things that look like blood draw vials, the red one means you have a positive HIV RNA test. So blood was drawn, it went to the lab for a PCR-based assay, and you have a positive RNA. A gray one is a negative HIV RNA test. This thing here, which looks like, a pregnancy test, a lateral flow assay, if it's pink, that's a positive non-RNA HIV test. This is usually an antibody test, but here what they're referring to is the combination of both an antibody test or an antigen and antibody test. So any non-RNA test is included in these little pregnancy test things. So the pink ones are positive and the gray ones are negative. And then down here, we have an indicator of when they received their last pre-exposure prophylaxis injection. So if they're blue, they have not had CAB-LA within the last 6 months. So they've missed at least 2 injections and are coming in at the time point for the third, because it's every 2 months, or they've missed longer than that. And the yellow is that you've had an injection within the last 6 months. And I'll just note here that in some of the early studies of CAB-LA, I think they reported the rates of being able to detect CAB-LA at any level at all, lasting for, in upwards of 1 year. I have it in my memory, I have it as long as 3 to 4 years, but regardless, that's not a therapeutic level, it's just any evidence of medication. So while the therapeutic interval is every 2 months, the people who've had CAB-LA within the last 6 months will likely still have some amount of medication, depending on how long they were on. And Charlie and Ethel can correct me if I'm wrong on that. But no injection within the last 6 months is blue. And so what did they find? So out of 26,500 visits, there were 73 that had one or more reactive or positive HIV test results. This included 42 people who were judged to be HIV uninfected, the blue people, 2 people who we still don't know, and 29 people who were judged to actually have HIV. So now let's look at the people who are blue. So these would be individuals who had a false positive test. They were adjudicated to not have HIV, but they did get a positive test. So what kinds of tests were positive in these false positives? And here you can see that in 20 of them, the HIV RNA test was negative, and the antigen antibody or antibody test was the one that turned positive and was subsequently confirmed, overruled. And in 22 of these cases, the HIV RNA test was the one that was positive, and the other combination strategy was the one that was negative, and then subsequent testing confirmed that the HIV RNA was in fact a false positive result. Now let's look at the true positives. So there were 29 true positive cases of HIV. In 5 of those cases, the HIV RNA was positive, and the combination assay or the antigen antibody or the antibody assay was negative. And in 24 of the cases, both of these were positive. So in the majority of people who truly have HIV, both assays were positive at the time of detection. And this is with prospective HIV RNA testing at every visit. In a handful of cases, there were an RNA positive only result, and the other result was negative. They don't report any cases where the antigen antibody testing was positive and the RNA was negative, although that may have something to do with the definition, and it's possible, I don't know, it's possible that some of those people may be the unknown status at present. Okay, so now let's zero in on the isolated RNA positive tests. So these were cases where antibody testing was not positive. So your rapid screen is negative, your 4th generation test is negative, but your RNA is positive. So what can we say about the RNA positive ones that were false positives versus the ones that were true positives? So if we look at this overall, and apologies, as I try to copy other people's slides, it doesn't always come out that well. So I'll tell you what it says. So the overall positive predictive value of having a single HIV RNA positive result, while you have a negative result of the others, is only 18%. So it's not actually that predictive at all of truly having HIV. If you look at individuals who've had CAB within the last 6 months versus those who have not, it is a big difference in efficacy. If you have not had CAB in the last 6 months, the positive predictive value is 60% that this is truly an infection. If you have had cabotegravir in the last 6 months, it's only 9%. So here, this would suggest that lack of recent exposure and HIV RNA test is more likely to be predictive. And then what can we say about the level of HIV RNA? Because this is something that we rely upon for people not on PrEP. So if you get back a false positive result that you think is a false positive, you look and see, is this 9,000 copies or is this, 2 copies? And what they can say here definitively is that in the, 2 things. So those that are below the limit of quantification but detected, so ones that would be reported as detective but below the limit, they're not undetectable, those are always negative on review of the case. So if you are reported as detected but below the limit while you're on CAB PrEP, based on the data we have, that means you don't have HIV. If you look at around 200 copies being a threshold for whether or not that's true, it seems like a reasonable divider between people who are truly positive and people who are not, but it's not perfect. There's people who are below the 200 copies, this one yellow dot over here in the true positive side, and there's one that's very close here on the false positive. So not 100%, but if you're greater than 200, there's certainly a higher likelihood that it's a true positive. So the good news is that if you did a second test, a second consecutive RNA test, it was negative 100% of the time. So just doing 2 tests totally resolved the problem for the false positive. So if you had this false positive HIV RNA, you did another test at the site, it 100% of the time resulted negative and cleared the individual of any concerns about HIV status. And in fact, there was also 100% positive predictive value for repeating the test if you were positive only the first time, which always led to either a repeat HIV positive RNA screen still with a negative antibody screen, or a double positive screen at the second time. So that does appear to work well. So their conclusions were that a single isolated positive RNA result performed poorly for detecting HIV infection with CAB-LA PrEP. There was better performance if you had not had cabotegravir for the past 6 months, and repeat RNA testing discriminated true and false positives with excellent efficiency. And then, although infrequent, most single HIV RNA positive results were false positive. And they did note that in 1/3 of the cases, it led to a delayed injection of a planned cabotegravir PrEP treatment. So this brings us back to where we are now, which is the current CDC guidance is to test for HIV with an antigen antibody and an HIV RNA assay and assess for signs or symptoms of acute infection at all bi-monthly cabotegravir injection visits. And so with these results, you could make the argument that this may not be necessary and in fact could be causing harm if we're delaying injections or responding to false positive results. I will say, I think from a global health policy, and so the first question was in fact about how to implement this on the global scale from one of the WHO advisors. The question was, how do we interpret this? And I think from a resource limitation setting, reconsidering using HIV RNA screening probably is appropriate. In a setting like ours, in which we can, in most cases, and in particular in patients who are engaged for PrEP and are often willing to return for repeat testing, we can easily resolve these by just repeating testing. I'm not sure what the right answer is, because we could potentially avert some cases of integrase resistance by identifying cases. Again, the rate of that occurring with on-time injections was extremely low. So it's hard to know whether or not that is cost effective. So I just thought I would pause here and see if people had thoughts about this. I think, the data from the original trial showing that you could identify people before integrase resistance was like, okay, great. Well, then we'll just definitely do that. That was with retrospective testing at a centralized site. This is applying it in the real world in a multi-center, multinational study. And I'll also just briefly mention that 1/2 of the false positive results in the study, 11, came from a single site. And they did what was described as extensive and exhaustive review of local procedures and were not able to identify the reason for this high frequency of false positive results from a single site. But it does suggest, again, that maybe there's ways for this to be used effectively and ways that it can go awry. So I don't know if anybody, I know Ethel and Charlie have thought deeply about long-acting use. I don't know if Kristen Kilcrease is on, who has done so much with our PrEP program, but I gotta say, personally, I'm not quite ready to not check HIV viral loads for individuals who are on CAB-LA. I think I would still do that with the plan to follow up with an HIV RNA test, but I wouldn't be surprised if some of these policies change as a result of these new analyses.
Eileen, can you clarify for the people who tested positive and then were negative on subsequent testing and were ultimately determined not to have HIV, were those people started on fully active ART with the first positive?
So that's a really good question, and I don't know the answer to that. They didn't actually clarify what the site procedures were. My understanding is, so in 1/3 of those cases, people had delayed injection of their CAB. I think it's unlikely that they had addition of medications on top of that, but that was not specifically stated. So it's a good question, but I don't know. By guidelines, if you think someone has acute HIV and they've been on a long-acting integrase regimen for PrEP, you would start a PI-containing regimen in the United States for concern for acute infection if you were doing immediate initiation. I'm not clear what was done by study procedure here, but thanks for that question, Mike. Charlie, you're so polite.
So I have a microeconomic comment and a macroeconomic comment. My microeconomic comment is that true failure on a cabotegravir PrEP regimen, particularly failure with INSTI resistance, is, we now think, so rare that, you know, doing HIV viral loads on everybody at every visit forever, or as long as they're on PrEP, is likely to be hugely cost ineffective. It's going to cost, you know, it's going to be hundreds of thousands of dollars to prevent a single case of INSTI resistance. So, you know, that's kind of a public policy question from a clinical practice question. Obviously, no one wants their patient to become HIV infected with an INSTI resistant virus, but there you, that's just thinking about it, trying to think about it in terms of, is the juice worth the squeeze or not? And I recognize that, you know, most people probably feel like you do. Nobody wants their patient to get INSTI resistance, so we're going to keep testing at every visit, recognizing that we're going to be wasting a lot of time chasing down false positive tests. It's just a fact. So my macroeconomic question is, based on your first presentation, who's going to want cabotegravir PrEP with lenacapavir available? I personally can't. I mean, I guess I think the people who aren't going to want lenacapavir are the few people who develop a horrible injection site reaction with pain and a nodule that persists for months, and they're going to come back to the clinic and say, no way am I ever doing this again. So I won't say there's nobody who's going to want cabotegravir, but I think that number of people is going to shrink steadily. So that would be my other thought about all of this.
Yeah, I totally agree. And I think from a provider-based standpoint, to have the option to do a long-acting agent and know that failure is not going to affect a major class of oral available effective therapy is kind of advantageous, right? Like, you only need to see them twice a year, you get full protection, you know, and also then if they do go off the farm, so to speak, they can still come in and get Biktarvy, right? That this is the, for me, a pathway that makes a ton of sense. It's just going to depend on what access looks like. And I think from your both micro and macroeconomic questions, it's like, it's so hard, right? Because the cost of CAB is so high in some settings. And so then you're weighing the cost of an RNA test versus the cost of other potential interventions. And Jean Anderson, to your question, so these study participants, this was 083. So this is only cisgender men and transgender women who have sex with men. And when I say this, I mean the HIV RNA testing results. There is HPT in 084, which was specifically in women. And those results, that similar analyses have not yet been reported. The PURPOSE trial, on the other hand, was all cisgender women. So we have dichotomized by sex here in terms of these two sets of studies. But I just think it's amazing how one trial can drive the recommendation for repeat testing, and then sort of with their open label extension of application of this approach, show that may not be effective. I do think that the fact that 11 of the cases came from a single site is of high concern, even if they weren't able to identify a technical error. It seems like likely there was one.
And it's a sobering reminder that HIV viral load is not a great way to screen for infection, because there are false positives, and most blips, is what we used to call them, in fact, are false positives. Now, I know we don't usually respond to blips, you know, viral load of 200 or 180 in the clinic that way, but, you know, we need to remind ourselves that as a diagnostic assay, that's not a perfect assay, and it's not meant to be used for diagnosis.
Yeah, I'm also reminded of when I was a resident, Rochelle Walensky was doing a test in the emergency rooms in Boston for screening everyone for HIV. And I know that's our standard practice here. And it was actually stopped because the rate of false positives was higher than the rate of true positives, because the local prevalence of HIV was so low. And that was not with HIV RNA screening, that was with standard antibody screening. It was prior to 4th generation, so probably would have perform better now in some ways with our more advanced assays, but it's just also a reminder that screening tests applied to populations with a very low incidence of an event will also just be wrong, because that's the way statistics work.
Which would be my prior for why the lenacapavir on time trial was different than the non-on time trial, like more so just the pretest being so much lower if you were on time for lenacapavir. Is that what they presented, or did they think there was something unique about the viral dynamics of those getting on time lenacapavir?
No, in the purpose trial, there's no difference in timing. Because there were no.
I meant CAB for this trial.
Oh, right. So they for this trial, they didn't really look at on time. They looked at basically whether you were, I would interpret it as lost to care for some period of time, because if you haven't had an injection in more than 6 months, that's not falling into an outside of therapeutic window. That's falling into a lack of likely engagement, because it's not like you were like 3 weeks late these are every 2-month injections. So at more than 6 months, you've missed at least 2 and you're due for your 3rd. So I think, yeah, that's the statistic there.
Okay. Yeah. I guess my question was, the people who had missed for more than 6 months had higher positive predictive value. Did they posit that was due to, viral dynamics of the waning cabotegravir, or just due to the pretest probability being
Pretest
higher
probability.
Okay. Yeah.
Yeah, Mike, to your point, exactly. And similar to the performance of that assay at enrollment, right? Because this is also something that's recommended or was done at the time of initiation of CAB. And so they basically were like, well, this is the same at time of initiation. What's the background prevalence rate with no intervention? And then the test performs fairly well, because there's just more people who have incident HIV at that point. And so that's what they were interpreting the 6-month results to be similar to that at the time of enrollment. So a great point. Sorry, I missed that the first time you asked the question, but I got it the second. Okay, well, great. And then I'll just move on to the next thing I was going to bring up. So this was an HIV cure number 7. So this is just a summary of the people who have been reported to achieve an HIV cure specifically as the result of a medical intervention. There are people who are reported to have full remission and no detectable reservoir from spontaneous cure, but these are people who had an intervention and then have remained aviremic. So Timothy Ray Brown, who was greater than 10 years out from his transplant, he was on pre-exposure prophylaxis towards the end of his life, when he died from unrelated complications of an acquired, a recurrent cancer. But he had a long period of sustained remission. The London patient, Adam Castillo, who's close to 8 years, a Dusseldorf patient, and I included their names here because they've been public, and I think it's like just nice to be thankful to them in their willingness to come forward and to engage with the community. He's at about 6 years. The City of Hope patient, Paul Edmonds, at almost 4 years, and the New York patient, the only female on this list, who's at about 3 years. There were 2 other patients. So the Geneva patient, who was reported by Asier Saya Serion, I could only think of his first name, who was the Geneva patient. He was reported at IAS in 2023. Now about 32 months out. And this person is of note because they received a CCR5 wild type transplant, not a CCR5 deleted. All the other 5 above received CCR5 deleted bone marrow. And then there's a new Berlin patient. This is the one who was reported at this meeting, close to 6 years of viral remission, but also transplanted with a heterozygous CCR5 bone marrow and was heterozygous at baseline. So these are the first 2 cases in which having the CCR5 protection has not been shown to be absolutely required. And more will be revealed about what exactly was required to achieve it. In both cases, there was some graft versus host disease. It remains a hypothesis in the field that having some immune reaction of the transplant against the host immune system likely reduces the reservoir further. And I'll just mention also that the Minnesota patient and Boston patients who did not have Delta 32 transplants, but were maybe thought to have been cured from a series of chemotherapeutic interventions, both rebounded. So it has never, other than these cases, worked. And I think one other really important point is that we actually don't have a very good handle on the denominator of individuals with HIV who've had a transplantation, their CCR5 status of the transplantation, and the overall results for their reservoir. So we don't know what the likelihood of achieving these outcomes is, even if you have the sort of preferred transplant, because most of these cases are sort of, they're certainly not randomized, they're certainly not blinded, and they require a patient to engage in a research program at a time of really severe medical intervention, which is not certainly for everyone. So that was another splashy update. I wasn't going to go through any of the other things. It shows the usual things one would expect: waning antibody and other immune responses as time off medications continued, and no evidence of HIV returning. So then I wanted to talk about something from the REPRIEVE trial that was presented at this meeting. So this is the current DHHS guidelines about use of statins in individuals living with HIV between the ages of 40 and 75 years who have low ASCVD risk scores, so between 5 and 20%. I'll just mention that I pulled up this figure here on the right with one of my patients recently and talking about this, and he actually did decide to go on a statin, although previously had been very sort of averse to being on any additional medications. And I do think this is something we should be talking with all of our patients about. But to summarize what REPRIEVE actually showed, they did show a 36% reduction in major adverse cardiovascular events with the initiation of pitavastatin, which is a high-potency statin, as compared to placebo in a multinational global trial of about 7,800 individuals living with HIV. So what is this analysis? So this was presented by Dr. Fichtenbaum from Cleveland, looking at abacavir as a modifier of risk of cardiovascular events in this REPRIEVE trial. And this is a topic that comes up a lot on this conference, so I thought it would be interesting to go through. So why look at this in REPRIEVE when there's all these other larger studies of population-based studies and things like that? So here are a couple of reasons why they felt like it would be a useful analysis. So cardiovascular events were independently adjudicated by the TIMI group, which is the major cardiovascular group that's based in Boston. So should have very high stringency of definition. It's a global trial with 7,800 participants and about 30% female participation. The age range, as I mentioned, 40 to 75, they were stable on antiretroviral therapy for more than 180 days, had a CD4 count greater than 100, and a low to moderate cardiovascular disease risk. I think the median CD4 count was in the 600s. So these are, in general, a very healthy population. So a lot of the potential confounders of cardiovascular risk from untreated HIV or other conditions are mitigated. And they were using contemporary antiretroviral therapy regimens. So the aim of this study was to evaluate prior and current ART exposure at entry and subsequent major adverse cardiovascular events. So the study design, so at entry, they took ART history and they included a history of exposure to selected agents. And those agents included abacavir, tenofovir, disproxil, fumarate, protease inhibitors, and thymidine analogs. Analyses in the intention to treat population were for the first major adverse cardiovascular event, defined as MI, TIA or stroke, revascularization, peripheral arterial disease, or cardiovascular death. And the median follow-up of these participants was about 5.5 years. The effect of ART type that they were investigating was estimated using a Cox proportional hazards model, and they stratified by treatment arm, of course, because the treatment arm mattered for outcome risk. And they show the effects both unadjusted and then after adjustment for risk factors that were previously shown to be associated with MACE in REPRIEVE. So I'll just call your attention here. This category, so the yellow here is the overall participation group, and then here is the no abacavir exposure versus abacavir exposure ever. And keeping in mind that individuals weren't randomized for abacavir exposure, the groups are unbalanced in size, with 6,000 in the no abacavir and 1,700 in the abacavir group. The median age was slightly higher in the abacavir exposure group at 52 compared to 49. Slightly lower prevalence of women, 24% in the abacavir group versus 33% in the no abacavir group. And then down here an ASCVD risk score. So the median ASCVD risk score for no abacavir was 4.2 and for abacavir was 5.4. And that's a small difference in percentage. And I don't know whether it could also have to do with the fact that there's slightly more males in the abacavir exposure group, but it's just something to note. Not the kind of difference in an ASCVD risk score that would totally make your antenna go up, but just at that cut point between less than 5% and 5% as the median. Okay, so what do we know about the abacavir use? So one thing just to notice is that most of the abacavir use was in high-income countries. So very little use in Sub-Saharan Africa, South Asia, and Southeast Asia, minimal in Latin America and the Caribbean, and then most of the exposure really in high-income settings, probably with the combination of Triamec. 22% of participants had ever been on abacavir. 9% were categorized as former abacavir exposure with a median duration of prior use of 3 years. And 13% were on abacavir at the time of randomization. Okay, and so what did they find? So here, the never abacavir is in yellow or orange, and the current is in purple, and the former is in blue. And what you can see is that there is a increased cumulative incidence of events in either the current abacavir group at 7.6%, the former at 9.7%, as compared to the never abacavir use, which was 3.74%. So when we look at, I'm sorry. There we go. Okay. Here they're looking at their Cox proportional hazards model. And if you zoom in down here with abacavir exposure category here, so never, former, or current, you can see that the unadjusted risk ratio, hazard ratios are 2.4 and 2.1 for former or current use, and the adjusted for other cardiovascular risk factors are 1.5 and 1.42. And the adjusted model components included age, natal sex, race, global burden of disease region, family history of CVD, smoking, hypertension, BMI, substance use, nadir CD4, HIV viral load, entry, baseline ART regimen class, so PI or integrase or NNRTI, and creatinine clearance, fasting glucose, and lipids. I should just mention that it was a requirement of the study to have an estimated GFR of greater than 60, so it's not representative of people with significant renal disease. So the results. So when they looked at hard MACE events, which is like another standard of determination, they saw the similar trend, but no significant difference. But overall, the results looked very comparable, just not statistically significant in this low incidence group. There was no impact of INSTI, NNRTI, or PI. That should be NNRTI, apologies for that, on whether or not that was combined with abacavir. There was no impact of other meds. So they looked specifically at current or prior use of TDF or thymidine analogs, and so no impact on MACE. And then there was, as I mentioned, they also didn't really have people with significant renal dysfunction to look at. That does not necessarily exclude people who had like a single episode of Fanconi syndrome from tenofovir and then were channeled towards abacavir. But that episode would have had to completely or primarily resolve in order to get your GFR back up over 60 at the time of entry. They did adjust for smoking. And I think one of the biggest questions, is should you stop or is the damage already done? And then Ashwin is asking in the chat if we can remind how they define former. Do they mean greater than a certain threshold number of months of exposure to abacavir? And it's a little surprising that the Cox hazard continues to rise even after that exposure is complete. And so, Ashwin, I totally agree. I think that's one of the most remarkable things of these findings is that, I mean, I don't know if this is, I mean, they're just separating over time, which I also think like the bottom line is coming up too, like as we get older, you know, some of this study had follow-up for some individuals of 8 years or longer. I'm not really sure that the former versus current is actually going to split. We would probably have to just keep following it. But they said that the median time of exposure was 3 years. They did not state if there was a qualifier of how long you had to have taken it in order to be considered to have had it. And we'd probably have to get as low as looking at the questionnaire details to see like, you know, were you ever prescribed it? And if there was a threshold for how many months they needed to have it. Dr. Fichtenbaum was asked this question, you know, if former exposure Yeah, they do both continue to rise, Ashwin. I agree, but so does the never. And I think part of that is just that as time goes on, more events accrue because MACE events occur. But is there something I'm missing? Feel free to unmute if you're not in clinic and unable to speak. But regardless, that it is notable. So it's kind of contrary to what the data shows. So the data would say, once you've been exposed, you have a risk. And in fact, that the formerly exposed individuals their risk is, if anything, slightly higher. But if there's a 40 to 50% increase in risk, a hazard ratio of 1.42 to 1.49 to 52, should you stop? He still suggested you should stop. And I think he was also saying, there's a lot more data about abacavir, and this is not the only study we've ever seen. He threw around the possibility of something like epigenetic modifications as a result of drug exposure leading to this outcome. I think that's a nice hypothesis, but would require a lot of testing to show. But they do in Reprieve have lots and lots of add-on studies, metabolomics and proteomics and other things. And it would be really fantastic to try to get a better understanding of exactly what's happening here. But I do think this is another piece of data to suggest that abacavir does contribute to cardiovascular risk, and that it's probably better to just not start it. And I still have like 1 or 2 patients who are on it, and I think about it every time I see them. But I don't know that this really changes how we would approach discontinuation, because it does, look about the same for current or former exposure. Oh, and we're at 12:59. I will just say really quickly to finish out the cardiovascular things that I was going to talk about. Some side notes from this session: dolutegravir impacts on hypertension on the global stage. This is looking at things like the ADVANCE trial and others where, there's now like millions of people on dolutegravir plus lamivudine or FTC plus tenofovir. The impacts on hypertension are likely mediated through weight gain. So that is how that pathway appears to operate. Dolutegravir itself was not associated with major adverse cardiovascular events versus efavirenz. Also, the data on the MACE were limited because it was a young, healthy population in South Africa. As many of you will recall, a couple of years ago, there was a paper from a Swiss cohort that suggested that integrase inhibitors might be associated with increased cardiovascular risk. Multiple studies since then have suggested that is not the case. This was another study that suggests that that is not the case, at least in this low risk, relatively young population in Southern Africa. And I think, coming back to Leon's point about what we can take from science, there was some presentations on non-communicable diseases and other comorbidities from Malawi and Cameroon and other global sites. And there was some questions about the discordance in achieving viral suppression versus achieving antihypertensive control. And one of the presenters made the point that in many of these countries, antihypertensive drugs have to be purchased by the individual as compared to ART, which can be supplied by the Global Fund. And as we make efforts to try to really address the many needs that the health of individuals, like this idea that we're adjudicating outcomes or trying to come up with mechanistic pathways for outcomes of associations between things like hypertension and HIV, including data from settings where people don't have free access, or even not free, but even just any access to some of these medications required for comorbid conditions, is really quite sobering. I think also in line with a lot of our own experience in our clinical setting, where there are so many competing priorities and we can't always get all of the things that people need done. So I will pause there and had a few other notes and things to share from the meeting, but as always, didn't exactly predict the timing. But if anyone has any comments or questions, Sonia, welcome back.
Thanks, just showing my face.
Oh, thank you. All right, well, thank you everyone for coming. Looking forward to the new year, and we'll talk about a few more things maybe on one of the other upcoming calls when we also do some cases.
Thanks, Eileen. Bye-bye.
Bye.